If I can do this, oh, if I can do this successfully here, I think this is going to be okay. Let's see here. Okay, great. I hope you all can see the slides. Excellent. So if I can. So what I'd like to do, this is a fairly small group. So by all means, if there's questions, comments along the way, please feel free, to stop me. I may not see your hand, so just, feel free to either raise a virtual hand. Hopefully I'll see that, or just simply tell me that you have a question and we can stop. So as Jose mentioned, mainly I'm going to be presenting on one intervention, but I'll also, towards the end of the presentation, talk about future directions and some of the things that we're working on. And I'll speak a little bit about one of our other interventions. And so as Jose said, this is a research program that I have been working on with many, many, many colleagues, quite frankly, too many to really acknowledge here by name. But I do want to thank, the entire Familias Unidas research team. And what's really special about this team, in addition to the incredible commitment and dedication that we show to the families and the science, it's also very much like a family. So we have all been working together, all of us for at least 10 years, and most of us even for 17, 18 years, which is really nice. So with that said, here's what I'm hoping to do today in the next hour or so. Hoping to very briefly just characterize the Hispanic adolescent population, talk a little bit about some of the disparities that we see in this population. Then shortly thereafter, begin to move to speak about the Familias Unidas intervention. What is it? What is it? What is this theoretical foundation? What is the content of the intervention? And then moving towards presenting some of the findings of our past studies, specifically an efficacy and effectiveness study that we completed a number of years ago. And then I'm going to transition to online adaptation of the intervention that we developed a number of years ago, and then speak a little bit about some of the work that we've been doing in terms of translating the intervention into practice and scaling it out to other settings. A lot of our work started in the school system. So some of the work that we've been doing scaling out to primary care, and also some of the work that we're doing in terms of scaling up the intervention and really disseminating it widely across cities in the US and in Latin America. And then I want to just give you a little bit of a snapshot about what are some of the things that we're currently working on. And then also, some of the things that we hope to be working on in the next year or so, hopefully with new grants coming in. So with that said, I know that I'm probably preaching to a choir here in terms of the Hispanic population. So just very briefly, the Hispanic population has seen unprecedented growth over the last 50 years, and certainly in the last decade that has been no exception. For about 51 million Hispanics in 2010. As of 2020, we have a little over 62 million Hispanics. So that's about a 24% increase in the last decade. And that considerably outpaces the growth that we've seen in the general US population, which is about a 7% growth. In terms of disparities, there are some significant disparities between Hispanics and other segments of the US population, specifically compared to non-Hispanic whites. There's much higher HIV infections, new HIV infections in the US. There's higher rates of illicit drug use, specifically among Hispanic adolescents compared to, as I said, non-Hispanic whites. And also, Hispanics are more likely to have a major depressive disorder than non-Hispanic whites. In addition to that, Hispanics relative to predominantly non-Hispanic whites are a larger risk of being overweight and obese. And again, you see some of the data in this particular chart here, where approximately 38% of Hispanics pediatric populations report having an unhealthy weight, and that's both overweight and obese. Family plays a central role in the development, as all of you here, I'm sure know, in the development of adolescents, and certainly that's no exception to Hispanic youth, particularly where in Hispanic families, It's a very collective culture where family really does play a very prominent role in the development of that youth. And so parenting styles, family functioning, things like parent-adolescent communication, family support for the adolescent, parental involvement in the adolescent's peer world, in their school world, in their peer world, are all protective factors of Hispanic youth in terms of their relationship to drug use, illicit drug use, sexual risk behaviors, and others, which are some of the things that we target in the intervention that I'll be speaking about in just a few minutes. So briefly, what is Familias Unidas? Familias Unidas is an evidence-based, Hispanic-specific intervention for Hispanic adolescents and their families. Typically, and I'll be speaking a little bit more about this over the course of the presentation, we have typically worked with adolescents 12 to 16 years old. Typically, in most of our research studies, we have focused on 12 to 13-year-olds because we want to get those youth at a developmental period before they start engaging in some of the behaviors that we target in our intervention and that we want to prevent. Again, drug use, sexual risk behaviors, alcohol use, cigarette use. The intervention is delivered through 8 multi-pairing group sessions where parents come together in a group format, and through a participatory process, they learn different types of skills, including skills around having effective communications with their children, showing parental warmth and positive parenting towards their youth, and being involved in the school and in their peer worlds. One of the unique things about this particular intervention that in addition to the 8 multi-pairing group sessions, there are also 4 individual family sessions where the adolescent and the parent or parents, or in some instances, it may be some other primary caregiver, where the family as a unit has an opportunity for the parent to practice some of the skills that they learn in the group sessions with their own adolescent.
Ay, Dios mío, qué bella, da un beso.
And sorry, I think there may be someone who's not on mute. And the intervention has been cited as an evidence-based intervention. It's listed in a number of different registries, including but not limited to Blueprints, CDC's Compendium of Evidence-Based Interventions, and when SAMHSA had the NREP registry, the National Registry of Evidence-Based Interventions and Practices, Familias Unidas was listed on there. Of course, NREP was removed during the prior administration, and my understanding is that there's plans to revitalize NREP with the new administration. What is the theoretical background and what are the intervention targets of Familias Unidas? Familias Unidas is grounded on eco-developmental theory, a framework that Jose Shapasnik and Doug Coatsworth developed back in the 90s, actually when I was starting at the Center for Family Studies. And it builds on Bronfenbrenner's work on the social ecology, which posits that individuals are influenced by a number of different systems, including those systems that are most proximal, in this case, to the adolescent. And those systems are the family, the school, and the peer worlds. And we target in the intervention risk and protective factors associated with each of those 3 worlds, with our main focus being on the family world, but also with a focus on the peer and the school world. We also, the intervention also posits that we target risk and protective factors that are more distal to the adolescent, and such as, for example, issues around culture and acculturation, which I'll speak a little bit later in the presentation about. I want to show you a snapshot of what our 8 pairing group sessions and our 4 family sessions look like. So the intervention is 3 months in duration, as I said. There are weekly sessions. Some of those are multi-pairing group sessions. Some of them are family sessions, but they're delivered on a weekly basis. The goal of the intervention, as I mentioned, most of the sessions, as you can see, 2/3 of the sessions are delivered exclusively to the parents without youth participation, because really the goal of the intervention is to really empower the parents and restore them to be the leaders and the agents of change within the family. And so our first session of the intervention starts with engagement and orientation to the intervention itself. There's a big emphasis on engagement. And what I mean by engagement is, what are the barriers for participants, for parents to participate in this particular intervention? Whether it's transportation, whether it's child not having someone to provide childcare for another child in the family, whether it's there's some resistance by another parent or another member of the household in having that individual participate in the session. So we tried during that initial session to problem solve and address some of those barriers to engagement in the intervention. Then, as you see from the remaining sessions, there's a big emphasis on the family world, and we target, as I mentioned earlier, enhancing communication skills, family support, parental monitoring of the adolescent's peers as important topics that we target in some of the group sessions. We also have some, even though the intervention is very process oriented and we focus on building these general skills, there are also a couple of sessions that are very content specific that focus on adolescents' sexual risk behaviors and drug use. Want to present on some of the work that, and actually I think I'm going to use this figure, which I like a little better. This figure comes from Hendrix's Brown article in the Annual Review of Public Health. And it really sort of shows the stages of intervention development and testing. And so with the Familias Unidas intervention, we have really tried to sort of model this figure where we started out with a lot of pre-intervention focus groups, cohort studies that really informed the development of Familias Unidas. After that, we completed a series of efficacy studies. We actually completed 2 efficacy studies of the intervention. And really the goal of those studies, which were highly controlled, was really to answer the question, does this intervention work in a highly controlled research environment when the intervention is delivered by our own facilitators, when there's a lot of monitoring and supervision, even of our own facilitators, and when we're working with a fairly homogeneous sample of Hispanic youth. As I mentioned, a lot of our work has focused on working in partnership with the school system, on recruiting from the schools. And during our efficacy studies, we were working with a small number of schools in the Miami-Dade County area, namely 2 or 3 schools that we worked with in all of our efficacy studies. As we started thinking about our effectiveness studies, really the emphasis was on how do we make this type of program work in a real world setting. And so our effectiveness study, as you'll hear about in a few minutes, we really worked with approximately half of the middle schools in Miami-Dade County. We worked with a very heterogeneous Hispanic population. We worked with very affluent Hispanic youth who we recruited from Key Biscayne or Coral Gables, which are very affluent areas in Miami-Dade County. And we also worked with populations that were less affluent. For example, we worked with the migrant population in the Homestead area, for example, and in related areas. So our goal really there was to see, all right, does this intervention work in a heterogeneous Hispanic sample when the intervention is delivered by school counselors, as opposed to our highly trained facilitators, and when the research team is significantly less involved in really only doing training and monitoring of the facilitators. We've also done a lot of work in the area of implementation. In fact, one of the studies I'll speak about later on today is a recently funded effectiveness implementation type 1 hybrid study, where the focus of the study is not only looking at youth and parent outcomes and testing for effectiveness, but we're also looking at sustainment of the intervention in these clinical practices, even after the research team pulls out. and looking at other implementation related outcomes as our primary outcomes. So all of this is sort of what I hope to cover in the next 40 to 45 minutes or so. So our first study, actually, Jose was the PI of this first study, this first efficacy study. And again, I'm very grateful to Jose, who supported me submitting an R03 during my doctoral program to really build off of the parent study and to look at questions around mediation and moderation in the parent trial. And so in this particular study, this was 3 very active attention control conditions that controlled not only for the dosage of the Familias Unidas intervention, but also controlled for the format of the intervention. So both the HIV preventive intervention and the health promotion intervention, which there was some data backing the initial efficacy of these interventions, or at least the promise of these interventions, really controlled and had a group format. Again, parents were the agents of change. Parents got together in a multi-group parent and sessions, much like they did in the Familias Unidas intervention. And also, they also had individual sessions with the family where, again, parents had an opportunity to practice what they learned in the group with their own youth. The goal of the intervention of this particular study was to evaluate the efficacy of Familias Unidas relative to these 2 attention control conditions in preventing and reducing cigarette use, illicit drug use, there as you see on the far right, alcohol use, and also unprotected sex. And we hypothesized that the intervention, Familias Unidas, would improve these outcomes through changes in or improvements in family functioning. So again, positive parenting, parent-adolescent communication, family support, and parental involvement. So really, we proposed that family functioning was the mediator between the intervention conditions and the proposed outcomes. Very briefly, for this particular study, we recruited and screened about 400 and plus Hispanic youth and their families. We ended up assessing and randomizing 266 Hispanic youth and their families into one of these 3 conditions. And we followed these families up for 3 years post-baseline. 6 months coincided with just a couple months after the end of the intervention. And then we had a 9-month or 12 months post-baseline, a 21-month post-intervention or 24-month follow-up, and then a 3-year follow-up. The youth in this particular study were all 8th graders at intake at baseline. And so we really had a unique opportunity to follow these kids through the last year of middle school and through the first couple of years of high school, which is really where we see during that transition period an increase in rates of the outcomes that we were targeting: drug use, alcohol use, risky sex, and cigarette use. As I mentioned, we were working predominantly with 13-year-old kids. There you see the average age, approximately a 50% split between males and females. We were working in this particular study with a fairly low SES family. So you see that almost 60% of our families reported a family income below the poverty line. When this study was conducted, what that translated to was about $19,900 for a family of 4. So you can see very, very low SES. In this particular family, the vast majority of our adolescents were foreign born, mostly at the time from Cuba, but also representing other countries in the America. And over the years, as the demographic population in Miami-Dade County has changed, the number of Cubans in our studies has significantly decreased over the years. In fact, now most of our participants come from South America and mostly Venezuela and Colombia, which is really consistent with what we're seeing with the immigration trends to the state. In terms of what some of the findings are, I don't want to spend a whole lot of time here, other than really just to say that we did have a significant impact of the intervention on a number of different outcomes, including but not limited to cigarette use, and you see that on the right-hand side. And what we also see, which is fairly consistent with what we see in all of our studies, is that we see changes in family functioning, and you see that changes in family functioning increase during the active phase of the intervention. And then what you sort of see on the left-hand side is a leveling off of the effects of the intervention in terms of our improvements in family functioning after the active phase of the intervention, which is the 3 to 6 month period. So you sort of see that leveling off, and that it's a pattern that we have seen consistently trial after trial. What I really like about this particular graph, actually, there's two things about the graph on the right, is that this sort of really shows what we saw, what we demonstrated empirically, that we really did see sort of family functioning function as a mediator here. We saw the improvements in family functioning from baseline to 6 months. And subsequently, we see the improvements in the outcomes. In this case, we see the reductions in cigarette use from 12 to 36 months in the Familias Unidas intervention, where we see increases in the other two interventions. One of the things I'd like to point out here is the heart condition. In heart, although I didn't describe it earlier, our heart condition was a cardiovascular intervention. And as I mentioned, it was multi-parent group sessions and also individual family sessions with the youth. And the goal of the heart condition, or the cardiovascular condition, was to target risk and protective factors associated with cardiovascular disease, including but not limited to risk factors associated with diet, physical activity, and cigarette use. And so one of the things that the heart condition was intended to do was to encourage parents to speak to their youth about the importance of not engaging in certain behaviors. And one of those behaviors was cigarette use. Now, what the heart condition didn't do, that the Familias Unidas intervention did do, was that it didn't target general communication first, and it didn't focus on building effective communication skills with families before telling the parents to talk to their kids about not smoking. And so what you see here is that in this cardiovascular health condition, we see higher increases in cigarette use relative to the other two conditions. So one could say that potentially there were iatrogenic effects in this cardiovascular intervention. So for those of you who may have kids at home, if you don't have great communication, you may want to think twice about telling your youth not to engage in smoking, because in fact, it's what they may end up doing. And the reason why I say may is because what we didn't have here, and I think it's one of the limitations of this particular study, is that it didn't have a standard of care, prevention as usual, control condition where we really would have been able to see what the developmental trajectory would have been in this youth if they would have not received any intervention whatsoever. So it's possible that rates, smoking rates would have gone from 3 or 4% to perhaps 25% in the full control condition, where in fact then the heart condition may have had some modest impact. But that's a question we certainly couldn't answer here. Moving on to our effectiveness study, as I mentioned earlier, we worked with approximately half of the middle schools in the county, and we had the school social workers and the school mental health counselors delivered the intervention. Our research team was really only responsible for the data collection part of the study and in providing a 1-week training to our social workers and to our school counselors, and then monitoring for fidelity to the intervention. For this particular study, we recruited and screened, and we recruited and randomized almost 750 families, of which half of them were randomized to the intervention arm, Familias Unidas, and the other half were randomized to community control. So what was community control, you may ask? So for us, this included a very modest curriculum that was offered at the time in health education classes to all 8th graders, and there was a significant emphasis on HIV prevention in that health module. This was done live, but certainly we didn't control for dosage or format in this particular study. We followed up, much like in our prior study, we followed up families at 6 months post-baseline, and then again at 18 and 30 months post-baseline. We did pretty well in terms of the percent of families that we were able to retain in our assessments, as well as you'll see in terms of the number of families that we were able to retain in the intervention itself. The characteristics of the sample, similar to our efficacy studies, as I mentioned, but a little different in the sense that we had, a subpopulation of the larger 746 was a little bit much more affluent than in our past efficacy studies. Talking about participation in the intervention, almost 80% of our families engage in the intervention. How was engagement defined, you may ask? Engagement was defined as attending at least one of the first 3 sessions. Our work, Jose's work and my own work in treatment and prevention respectively, really shows that initial engagement is a very strong predictor of continued attendance in the intervention. So again, we really did put a significant focus on ensuring that a significant proportion of our families engage so that we can increase the likelihood of retention to the intervention. With that said, we had about 6.5 sessions attended across. This included the 22% that did not engage. When you separate and you exclude the 22% that did not engage in the intervention, the average session attendance among those that engaged increased to about 8.5 on average. Here's a snapshot of what the base rates were in terms of the different health behaviors that we were targeting. This is pretty consistent with the prevalence rates of these particular behaviors in a universal population as reported by the YRBSS for the Miami-Dade County area. In terms of some of the findings, much like in our efficacy study, we did have findings on our primary outcomes. Here, this was past 90-day drug use and sex without a condom and last sexual intercourse. And you see some of the test statistics here in the model fits, which I won't go over. We've had a number of different colleagues, Hendrix Brown, Tatiana Perino, George Howe, and Annalie Brinks, have done over the years a number of really neat studies looking at the crossover effects of Familias Unidas intervention for a number of different outcomes, including, but not limited to, internalizing symptoms, specifically anxiety and depression, and also looking at suicide ideation and behavior. And what a lot of those studies have shown, as this particular study by Tatiana Perino, is that the Familias Unidas intervention has an impact on trajectories of internalizing disorders for those who are highest risk at baseline. And the way that we have defined high risk at baseline is those families who report poor communication at baseline. So it's a pattern that we've seen not only in this particular study with trajectories of internalizing disorders, but also we've also seen similar findings looking at suicide ideation and suicide behaviors as well. And what we have also seen is that communication has mediated the effects of intervention on the outcomes, again, for that subset of families who reported poor rates of communication at baseline. So we have seen some really nice moderated mediation effects of the intervention on a number of different outcomes. And again, as I said, we've seen that in a number of different outcomes. One of the outcomes for which we have seen that same moderated mediated effect was for physical activity. And in fact, that really led to the development of an adapted version of our Familias Unidas intervention to target physical activity and quality diet. So this was a study that we completed about 3 or 4 years ago now that was funded by NIMHD. So here were the 2 aims of this particular study. One was to examine the relative efficacy of this adapted intervention in increasing physical activity and improving quality diet among Hispanic youth who were overweight or obese. and their parents. So we focus not only on the adolescent outcomes, but we also focus on the parent outcomes as our primary outcomes. The second was, to really see if we saw improvements in BMI and blood pressure among Hispanic youth and their parents. And so those were our secondary outcomes. One of the things that I think our team, and I know that many of you, and again I start with, it sort of comes from the top, when Jose was a great mentor to me and to many others. I have also had the good fortune of really mentoring really wonderful graduate students and really amazing postdoctoral fellows over the years, all of them who have come from underrepresented minority groups. And so the first one here is, Sarah St. George, who, with me really led the adaptation of the Familias Unidas intervention for these particular outcomes. And much like we do all of our intervention adaptation and intervention development work, it really follows a multi-tier process that consists of initial focus groups, a pilot study of the adapted intervention with some additional focus groups halfway through, and then at the very end. And then also, some feedback from other individuals who were involved in the intervention. In this particular case, the intervention was being delivered, or partly delivered, I should say, by park coaches from the Miami-Dade County Parks and Recreation System, and from our own research team facilitators. So there was an iterative process in the development of this intervention, which Sarah St. George played a significant role. And since then, Sarah has become a faculty member, is on a tenure track faculty position, has her K award that's coming to an end, and just submitted her first R01, which I'm happy to say scored well. Probably not enough to get funding, but I'm hopeful that she will have her first R01 certainly within the next 8 or 9 months. What does the adapted intervention look like? So as one of the key differences that you'll see here is that we did have some specific focus on unhealthy behavior, specifically in group session 5 and in the family session 3, where we really did focus on some of the content around physical activity and quality diet. So that was one difference. Another difference is that the group activities before in our Familias Unidas intervention, our group activities between the parents were 2 hours in duration. We really focused the content of the intervention, and we eliminated some of the focus on drug use and risky sex to make room for these very specific activities that were focused on diet and physical activity. And I should say that all of these activities that you see here that were done in the second hour were done, parents and youth did those activities together. And again, consistent with the theoretical framework of the intervention, we really aim to place parents as the change agent of the youth and really help the facilitators work with the parents to help guide their youth through these different activities. I do want to point out that even though we did trim a lot of the content that focused on substance use and risky sex, we did keep a little bit of that focus on substance use, and we did keep our sessions on risky sexual behaviors. For this particular efficacy study, we randomized and assessed 280 Hispanic families, half to the intervention arm and half to the prevention as usual. And much like we did in our past studies, we followed these families up for a couple of years as well. Here's what the demographics look like for this particular study. Again, you can see that pretty consistent with what we've seen before. We did see a slightly higher rate of US born in this particular study. So you may recall in the first study I presented, we had 60% were foreign born. In our effectiveness study, we had about half and half. And this one here, we start seeing a trend of having more US born than foreign born, a trend, quite frankly, that we've continued to see over the years. as we have more second and third generation Hispanics in the Miami-Dade County area. Here you see a breakdown of the demographics of the primary caregivers. The vast majority of their were moms, very few parents that we were able to engage in the intervention. And the average age was about 42, and the vast majority were married, and another substantive percent were living with a significant other or partner at the time of the study. I won't go through this in tons of detail, other than consistent with what we have seen in some of our other studies. We see significant effects and significant improvements in most of our family functioning indicators between baseline and 6 months. And then again, consistent with what you saw before, we sort of see a leveling off after the post-intervention assessment through our 12-month and 24-month follow-up. But you see improvements in a lot of these. How about improvements in our parent and adolescent outcomes? Interestingly enough, we saw significant effects on our parent outcomes, specifically on indicators of quality diet, and also on BMI. We did not see improvements in the parents' blood pressure, nor did we see improvements in the adolescents' quality diet or BMI or blood pressure. So it was interesting, and we can speak about this later on as to some hypotheses as to why we saw improvements in the parents and not the youth. Our team has also been, over the past 7 years or so, been pretty active in thinking about how can we take the Familias Unidas intervention and make it more accessible to a larger segment of the US population. So about 7 years ago, we started thinking about adaptations of the intervention to an online delivery format, where we really wanted to maintain the core ingredients of the intervention, but we wanted it to have a significant online component where we didn't need a facilitator to deliver the intervention. And the goal really was not only to, of course, to maximize the efficacy and retain the efficacy that we had seen in our prior studies, but also to maximize reach, which of course, having facilitators deliver 12 sessions to families really sort of speaks about how scalable is this, and can it really reach a large segment of the US population and broader population. So again, talking about early career faculty who I've had the pleasure of mentoring, here is another one, Janine Estrada, and she was funded to do this initial intervention development work through a mentored K-like, it wasn't a K, CDC has another mechanism, but through a K-like mentored award. And Janine also is in a faculty position and also just submitted her R01. So happy about some of that progress that she's making. In terms of what is this new online eHealth Familias Unidas intervention? As I mentioned, really our goal was really to retain the core elements of the Familias Unidas intervention. One of those core elements that we were really looking to retain was to continue to have the parent be the agent of change in the family, and also to continue to have the intervention be participatory in nature. And I'm going to hopefully describe to you how we mimic that participatory nature of the intervention. We also wanted to entertain, the parents that were going to be watching these videos, while being very engaging and educating these parents as well, which again was sort of one of the goals of the intervention. Now, I'm going to tell you how we did that. We still continue to evolve, but I think you'll find the core ingredients and the core elements of the intervention to be interesting. As I mentioned, another goal was really to think about the scaling up the intervention and making more accessible, and also really to increase the rates of participation in the intervention. As I mentioned earlier, one of the barriers to participation was issues around transportation, childcare, parents not being able to make a certain group at a certain time. And so we really tried to think about how do we minimize some of those barriers as a way to increase participation rates in the intervention. As I mentioned before, a lot of our intervention development and adaptation work really happens through an iterative process that consists of multiple steps. That was no exception in this particular study. It consisted of developing scripts for telenovela episodes that we ended up producing. We got feedback from parents, from youth, from some of the staff. We developed the intervention, we took them through the intervention, and we collected data, qualitative data along the way, which we have published over the years. So what did the intervention, what did it consist of in this study, and what does it still consist of? Actually, for the most part, we've made some adaptations, as I said, along the way. So the intervention has really two major components. The two major components are the group sessions. Much like before, we had multi-parent group sessions. Now we call them e-group sessions. And the second is our virtual family sessions. So let me start off with the virtual family sessions. So the virtual family sessions, it's what you see here, sort of the the mom and the child in front of a computer. And this takes the place of the 4 individual sessions that we used to do live, face-to-face, with a virtual telehealth, telemedicine type of session. So again, we started doing this 7 years ago. Of course, now with COVID, telemedicine, telehealth has become very popular. And many of us have probably seen physicians over the past 2 years through telehealth and telemedicine. So on the other side of the screen is a facilitator that's working with the family to deliver the session, the live family session. Now, what replaced the 8 multi-parent group sessions? So as I mentioned, it was replaced by these e-parent group sessions. Now, the e-parent group session had 3 components. The first component, which is what you see at the top, is a telenovela episode. And specifically, the intervention has 8 10-minute telenovela episodes that are everything you would want to see in a telenovela or in a soap opera. It's highly dramatic, overly dramatic, I might add. 2, there's a climax and a cliffhanger at the end of every episode, which we use to engage the parent and to hopefully have them come back to see the next session. And our second component is and by the way, I should say that these telenovelas, they map on to the 8 different topics of the face-to-face intervention. So as a reminder, when I presented the table of what the 8 sessions look like, and I said that one of them focused on communication, the other one on parental monitoring, the third on family support, these are the same topics that are introduced in each of the telenovela episodes. The second component of these e-group sessions is a talk show host format. So here it is. I'm pointing to it in my cursor. There's a group of 5 parents and our facilitator. This facilitator is a staff member that has been working with us for about 20 years now. She's what I call our Oprah Winfrey. She's our movie star. And what we did was that we brought in a group of parents from the community, and our facilitator, Maria, ran these 8 group sessions. And then we edited and trimmed down the content of these 8 group sessions from about 1 hour and 45 minutes to about 10 minutes. And while, again, retaining those core elements of the intervention. The third component of the e-group sessions was the interactive exercises. And this was our attempt to make the intervention as participatory as possible, much like in the face-to-face. So what did this interactive exercise, what did they consist of? So let me give you an example. So during their first session, the parents in our face-to-face intervention are asked, what are the goals for you and your child in terms of the 3 adolescent worlds that we have been talking about, which are the family, the peer world, and the school world. And parents have an opportunity in the live sessions to talk about what are their goals in each of these 3 worlds. So for example, a parent may say, one of my goals is to communicate more effectively with my child. So during this interactive exercise, the facilitator takes a pause and says, parents at home, what would you like to see in each of these three different worlds? What are your goals for your youth in each of these three worlds? And the parent has a long list of goals that come up on their screen of what are potential goals in each of the three worlds. And the parent has an opportunity to then prioritize those goals. And then what we do is that we take the information that we receive from those family sessions and from the completion of those interactive exercises to then tailor the virtual family sessions that mom and or dad have with their child and the facilitator. So does that make sense? Okay. So here's an efficacy study that actually Janine led, and it was 230 families. We randomized half of them to the intervention arm, half of them to the control arm, and we found, this was a study that had much more limited resources, and families were followed up for 9 months post-intervention or 12 months post-baseline. Here you see the engagement and retention rates. And so you see one of the things that we observed is that family participation was significantly greater than in our face-to-face session. So instead of the 78% engagement and retention rates, we had slightly higher, not significantly higher, 82% engage. But when we look at average session attendance, as opposed to the 6.5 that we typically saw in our efficacy studies, we saw closer to 9 in our effectiveness studies, which really was one of the goals to really increase the retention rates. So I would say mission accomplished in that regard. In terms of our outcome findings, we had significant effects on drug use, and when we broke it down by a number of different drugs, we saw that fairly consistently across the board. We did not see an effect on condomless sex, which we had seen in our prior efficacy studies. Now, we can speak about a number of different possibilities. Certainly one possibility that we believe is that these youth, much like in our prior studies, were 13 years of age. We only followed them up 1 year here as opposed to 3 years in our prior studies. And so these kids here were much younger, and their rates of sexual behavior, and specifically risky sexual behavior, were significantly lower in this particular efficacy study than they were in some of our past studies. But happy to speak more about that. We're also, over the past 5 years or so, we've been doing a lot more work in primary care settings. This was an effectiveness study that was funded by NIDA. And so I'd like to thank, the CTN certainly, and the youth SIG of the CTN for having me here, and really to also thank the NIDA DESPER branch and the Division of Prevention, who's been really a great supporter of this intervention over the years, and has supported, certainly some of the trials that we've conducted over the years. So this study in primary care, we literally already just finished recruitment. We're analyzing data. Where it looks so far, I can tell you we definitely have an effect on our primary outcome, which is frequency of past 90-day drug use. Looks like we have some improvements in family functioning. I don't know where we're going to see improvements in sexual risk behaviors. We don't have a significant effect on condom use, again, which is our primary outcome. And we're exploring other sexual risk behaviors, including but not limited to multiple partners. I know I'm coming to an end here. Oh, yep. Is that okay, Jose?
Yep, thanks.
Perfect. I know I'm coming to an end. So I'm going to finish up here in my last couple of slides. We've been doing a lot of work on scaling up the intervention. There's a big sponsored initiative with the Chilean federal government, where the intervention is being scaled up across the entire country. And sort of you see here from the south all the way to the north of Chile. And we've been doing the same thing here in the US. So with that, I know we only have 5-6 minutes left for questions, but I'll pause here.
Any questions? Are welcome, or any comments?
I have a question. This is Kevin Wenzel. I'm working at Mountain Manor Treatment Center in Baltimore, Maryland. And really cool presentation. Thank you for presenting to us. I'm really intrigued by this idea of using the online and video-based sort of intervention material. That's very compelling. I had more of a methodology question related to the family functioning scores. So we have some family-based interventions, and we're always struggling to capture this idea of family functioning and how to measure that. So I saw in one of your slides, you looked at communication and peer monitoring, positive parenting. Can you direct me to any sort of measures you use?
Sure, absolutely, absolutely.
Yeah,
sure,
that'd be very
Kevin, and I'm happy to do a little better than that if you like, and if you put your email in the chat or if it gets emailed to me, I'm happy to send you those measures that we use, and we have translated, and they've been validated in Spanish as well. And
Great.
the original measures were developed, a lot of them, not all of them, were developed by Deborah Corbin-Smith, Pat Tolan a number of years ago. And we've been using those same measures. And like I said, we've also translated them and done some validation work. So if you provide me with your email address in the chat, I'm happy to copy and paste it and happy to send that your way.
Thank you so much.
Of course.
Oh, hey there, thank you, Dr. Prado. I think the data speaks for itself here, but I kind of wanted to zoom out, ask something theoretical. Do you know, if you had to guess, what do you think about this approach is critical to working better with Latino families?
Yeah, it's a great question. It's a great question, and I didn't speak a whole lot about that. But this particular intervention is certainly very culturally syntonic, both the face-to-face and the online for that matter. And I'll give you one example. One of the things that we target, and actually Jose, I keep on referring to Jose, but he's sort of really a pioneer in the field, and did a lot of early work here in the Miami-Dade County area, talking about sort of some of the differences that he and his colleagues were observing in in acculturation, and how the youth and the parents were acculturating to the U.S. And so some of that early work showed that Hispanic families, parents and youth, were acculturating at very different rates, where youth were acculturating very quickly, and the parents were often not. And some of the things that were viewed as normative, or that are viewed as normative here in the U.S., for example, having a youth sleepover at a friend's house, were not viewed as normative by the parent because of their lack of acculturation to sort of the U.S. culture. And that's one of the things that we specifically target and talk about. And in fact, the parents often bring up during the course of the intervention sessions. And so we do some work in that area to reconcile some of those differences or discrepancies in acculturation. So, so this is sort of one of the ways in which I think the intervention particularly works well, for Hispanic families, Hispanic immigrants, where there may be some of these discrepancies. And again, there's other ways where we pay attention, very close attention to culture. This is just one of those ways by which we do that.
That's great. Do you guys offer a training for those of us, like my population is 40% Hispanic, and I think I see these problems, but I don't know how to effectively intervene them. Does your group offer a training in how to effectively approach that culture?
We do. So we we've trained, and I had two more slides at the end, some of the future directions, but we have trained over the years about 300 different individuals in the intervention. Some of them, many of them actually, we're now in 6 different states here actively. We've been working with 6 different states, counties, cities who are delivering the intervention, and in Chile certainly. We've been doing a lot of training, and we've trained individuals, and then they have taken it from there, so much like a train the trainer model. where, we train, 2-3 people, and then they take it and they've essentially run with the intervention, and as is the case in Chile, as one example.
Something that I would add is, I'm not sure what Dave is asking, because what I think Willy is saying is train in the intervention. The intervention is a whole package, which includes the cultural competence.
Correct.
So it's not just training on cultural competence, but in a whole package that includes that.
Correct.
Yeah, I think being trained in the whole package would be a good place to start. I don't know if we could implement it where we are, but I mean, I feel like you can never learn too many skills. And I really feel like we also need to be more mindful of how our efficacy rates are varying across cultures. And I'm not sure that many institutions are tracking that, but I think it is a big concern. I feel like we need more tools to be effective.
Yeah, and I'm looking at the chat, and I'm happy. I just saw somebody posted, if I can share the slides, and I'm happy to email those to the coordinators, and so that they can share with the group, of course. And one of the things I'll do, if it's just in case folks would want to see, I'll embed a link to a YouTube video so that you can get a sense of what the online intervention looks like, and so you can get a sense of what the telenovela itself looks like.